Welcome to Sports Doc Talk. I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, that man right there, Dr. Grant Garcia. Dr. Garcia, exciting. We have a new show. We have a great guest. But first and foremost, how are you?
I'm good. It's still sunny for another day or two. Summer's just stretching on in Seattle, so I can't complain. Unfortunately, the Giants are back to being terrible, which we don't have to talk about today. But the Seattle teams are doing well, decently, so that's good. Mariners won, so we're excited about that, I guess.
Yes, let's not bring up why are we starting off the show with the Giants. Dr. Garcia, man, you know,
It's
you like to
always,
push my
we
buttons.
need
We're not
something.
doing this
We
now.
had one game. We had one game.
Oh, my Lord. All right, man. Let's get to people that really care about us because obviously you're just trying to break my heart. Let's talk about the good folks at the recovery shop. Let's shout out to Contact Mike B. Talk about the recovery shop and why you love them, and our guest as well loves them as well.
Great. Yeah. So we like them because honestly, patients ask for a little bit extra sometimes. And it's challenging as a surgeon. You send them to, Amazon or online to look for their stuff. So the option of having this for the patients is really nice. And the patients do appreciate it too, because it's all kind of there together. And you have the nice machine, which Dr. Weil, I think, just tried out one of the new elbow devices, which is really nice for his patients. That's really a niche that many of the companies can't provide. So they've been really happy with them. And I think the patients are really happy, which is more important. So if you're a surgeon, reach out to them. If you're a patient, you don't have that option, reach out to them. They can try to get your surgeon set up with it so that you can have that opportunity.
All right, let's get right to our guest because we're keeping him from getting dinner, and that's a tease for something that we'll talk about later on. Let's bring in the doctor, the hand, the wrist, and elbow specialist himself, Dr. Wayne Weil. Dr. Weil, thank you for being on. Thank you for hanging with us. And I apologize for Dr. Garcia bringing up things to start off the show in a negative way. How are you?
Doing great. Happy to be here. Thanks for the invitation.
Yes. So for the viewers, introduce Dr. Wayne Weil. He's a hand surgeon. Actually, he's my partner. We do a lot of cases together, complex elbow surgeries, and he specializes in hand, wrist, and elbow, and then dabbles with trauma as needed. But really super specialized in the hand and nerve surgeries. Also chief of orthopedics at the Swedish hospital system, and board of directors. So he's got extensive title in ProLiance as well as Pelto. And he actually does family stuff as well on top of all that huge list. So pretty impressive. Well, thanks for coming on. Really appreciate it. I'm sure Will's gonna have lots of questions to ask too. For the viewers, do you think you can kind of give a quick background? I know you came from New York, talk about your stuff, and now you're in Seattle. So just give us a little update into who you are and where you came from.
Sure. Yeah, I'm an East Coast guy. Originally grew up outside Bethesda, Maryland. Ended up doing my college in Philadelphia, and then med school and residency in New York City. Then ended up out here for a hand surgery fellowship, and just kind of fell in love with the Pacific Northwest. And one of our other partners, Dr. Shapiro, who's a shoulder specialist here. I knew him from New York. He was a fellow while I was a resident, and he ended up recruiting me to stay out here. And now, 21 years later, I'm still here in Seattle. We now have 5 kids, and as Dr. Garcia mentioned, I've gotten involved in sort of non-practice stuff with being chief at Swedish and the board positions at ProLiance, and then I still have my practice where I really enjoy just treating elbow, wrist, and hand, and I do a lot of that, whether it's sports injuries and younger folks or degenerative stuff in older people, arthritis stuff. So kind of do a little bit of everything, except maybe sleeping, which I would like to do a little more of, but that's okay.
Dr. Weil, can you tell us what first sparked your interest in hand and microvascular surgery? How do you go along that path and have that interest?
Yeah, so that really started in my 4th year of residency. As part of our residency program at NYU and Hospital for Joint Diseases, We do a 4-month rotation down in Baltimore at Shock Trauma Hospital down in Baltimore. And at the time, there's a surgeon there, Andy Egelsater, and Dr. Egelsater, to this day, I think is the best surgeon I've ever seen operate. Just I think for lack of a better descriptor, gift from God in terms of he could do anything, and it was always perfect. And so he really got me interested in microsurgery, and kind of the rest is history from there. So it's, I think, in a lot of our lives, just exposure to a good mentor really can pave the way moving forward in terms of really career paths in general. And I think Dr. Egelsater is really the person who got me interested in what I'm doing today. And then fast forward a couple years, Doug Hannell at University of Washington, who I did my hand surgery fellowship, another just phenomenal surgeon. Doug, in a very similar way with Dr. Egelsater, could fix anything, and just an incredible surgeon. And so, having the exposure to those two docs in particular, I stand on the shoulder of giants, and I certainly give a lot of credit to those two guys for getting me to where I am today.
Wayne, I want to bring this up because I think that's probably your answer is going to be this too. But we see in the office, I do a lot of, we talk about the sports surgeries that I do, but I see you doing a lot of really complex hand and wrist surgeries that not everybody would want to take on, even as a hand surgeon. Do you think, and I don't want to put too many words in your mouth, do you think that stems from that background you're talking about, or why do that? Because your private practice, you could just do carpal tunnels and basic procedures. You don't have to do the hard stuff. Why do you choose to?
Maybe I'm just a masochist, but I think that's true of kind of all the guys in our practice. I mean, we could all just do the simple stuff, but I think we all enjoy the challenge. For me personally, I enjoy doing carpal tunnel surgery, but I would get bored if I just did that all day long. And for me, maybe I'm blessed with the ability to do the hard stuff, and I enjoy doing it. And I think that serves a niche for our patients, in terms of, we see a lot of patients in our practice, and you do as well, where, they've bounced around to different docs in the community, and just for whatever reason, haven't been able to get the care that they need. And so for me, it's very gratifying to see a patient who's maybe seen a few docs, and has been told, we can't help you. You got to live like this for the rest of your life, or whatever it is. And to be able to see them and say, actually, that's not true. That we can help you, and I can make you better. And I think, that's why we went into medicine, is to make people better. And, it's very gratifying. I think the more complicated a problem is, in a lot of ways, it's even more gratifying to get to the other side where you've made somebody better. And again, I think, going back to the training, both at Shock Trauma in Baltimore, both at Harborview, I mean, we saw the craziest stuff you could ever imagine. Horrible injuries, whether it's, explosives or industrial injuries or what have you. And, those two guys in particular, Hannell and Egelsater, they were just, always so calm, always had a plan, and able to execute it. And I think having that kind of exposure where you've seen, everything. So when somebody walks in the door with something complicated, you rely on your training and then your experience. I've been doing this now for 21 years, been in practice. So I feel like, there's not much out there that I haven't seen. And so that makes me prepared to take on the complicated stuff.
Awesome. So I know we talk about this, but obviously we might switch gears a little bit, but
Yeah.
coming from the complicated to maybe the more minimally invasive stuff that you do. I know we know you're one of the only surgeons in the area that does this sort of endoscopic carpal tunnel, endoscopic cubital tunnel. Will you talk a little bit about those procedures for the audience? And then what is the benefit, in your opinion, of doing it this way? I mean, it's also more challenging technically, but obviously, what's the benefit to the patient? Why would you do that versus a standard open?
Yeah. Well, I mean, the name of the game in, I think, all of surgery is, being less invasive, less destructive to the tissues. And that really, helps on the back end in terms of there's less stuff to heal, right? Again, going back to my residency, you'll appreciate this story. I was a third-year resident, and I scrubbed a case with a doctor who was the only one in the NYU system still doing open ACLs, and I'd done
I'm shivering, by the way. I'm shaking. I'm having like
you probably never even
formation.
seen one. So, and this is now circa 2003. So at this point, or 2001, at this point, arthroscopic ACL surgery was a standard thing. I mean, it's not like it was brand new. People have been doing arthroscopic ACLs for 15, 20 years, probably at that point. And so, so I scrubbed this case with this guy who's doing open ACL, and, the whole knee's filleted open, and I couldn't believe what I was seeing. And I can't imagine what the recovery from that was. And having had an ACL done on my own knee, arthroscopic ACL, I mean, it's worlds apart, and so that experience in particular was like, well, why would I ever do something that was that traumatic if I can do it in a way that's not nearly as destructive to the surrounding tissues. And so in residency, actually, we started doing endoscopic carpal tunnel releases, and again, smaller incision, less tissue invasion, and we'd have patients who had an open on one side and then came back and had the endoscopic on the other side, and they were like, every single one of those patients couldn't believe how much easier the recovery was with the endoscopic. Just less pain, quicker return to work, better function. And, the data has kind of borne that out when you look at the recovery. Again, just less pain, quicker return to work, and better grip strength in the first 3 months of recovery. The opens end up catching up in the end, and they do fine. And, at 9 months, 1 year, everyone's the same. But why have an operation that takes you 9 months to recover from when you can have the same operation, but it only takes you, 3 months? And so similar to the ulnar nerve, the cubital tunnel decompression in the ulnar nerve, same idea, is, little incision. We do everything from the inside out instead of the outside in. And so, again, you don't have to cut through any of the muscles to get to where you want to be. And that just decreases the amount of time for recovery and gets people going a lot faster. And I think that's really the exciting part in orthopedics, where we're moving towards in general, is all the stuff we do is becoming less and less invasive. You look at a hip replacement, you were in the hospital for a week when I was a resident. Now we do hip replacements and you go home the same day. Same with, knee replacements, a lot of the cartilage stuff that you're doing. All of it is really starting to become outpatient surgery. I mean, even spine surgery is moving to outpatient surgery. And you look at the results, people do better when they're home versus sitting in the hospital. You take the same operation, same person, your risk for infections and worse outcomes are higher if you stay in the hospital than if you go home. I think all of orthopedics, and especially in my specialty, trying to do things in a minimally invasive way, it just makes sense, and it's better for the patients. In a lot of ways, it's more fun for the surgeon because we get to play with cool new instruments.
High priority. That's the high priority there.
That's right. It's fun to go to the lab and kind of innovate and work with some of the companies to, come up with novel ways to do things. So I think it's sort of a win-win all the way around.
Will, can you pull up that slide on the nano? I want to see, because we're in the perfect example of segue. Go to the next slide. Here, let me just do it.
Yeah, I have it. Well,
yeah, Wayne,
right there.
Yeah. So this is good. I mean, we don't have to do the proprietary discussion here. I just was a picture because I know you've raised this before. So for your minimally invasive situation, I mean, what would you use something small like this for? Right? Like the idea behind patients are always curious, like, well, how small can you go? I've seen you scope some pretty small joints. I mean, I would never consider doing. So what are your uses of this, and like, how do you help? What does it help you with?
So we've gotten to the point now where the instruments have gotten small enough where, in the old days you could basically do a shoulder and a knee, and we've now gotten to where we can basically scope pretty much any joint in the body for the most part. You can scope out to even the PIP joint, proximal interphalangeal joint in the finger. You can scope, the base of the thumb. That's probably the most common one that I do now, because the base of the thumb, the carpometacarpal joint, that's the one that becomes classically arthritic. And so there's procedures now that we can do kind of like in the knee, where we do for arthritis, some clean out procedures. So the instruments, not only the camera, but also the different little shavers and the probes and instruments that we use are small enough that they fit in there. So you can really do kind of what the large joint arthroscopists do, the stuff that you do in the knee and the shoulder, Grant. Now I can do to some degree in the base of the thumb and in the wrist. And so we're definitely catching up, I would say, to the large joint arthroscopists, and a lot of it just has to do with the ability to make the instruments smaller and smaller. It's kind of like our computers and our iPhones and everything else in the world. The first iteration is big, and then as we get better with manufacturing and the technology, it just gets smaller and smaller and smaller. So then we can start really having a good time with the small joint instrument, small joint arthroscopy.
Would you say with this, I mean, when I first saw you do one of those thumbs, I was like, this is crazy. This is cool. Would you describe, like, what were you, like, for that patient, when you do the metacarpal, when you do the scope of the thumb for some arthritis, what were you doing before for them? right? Because these are patients, they're not old enough for fusion
Sure.
or any other thing. So what were you doing before? Is this at a new surgery for you?
Yeah, so I think of it like arrows in your quiver, right? And so you've got only a certain amount of arrows in the quiver, and if you can have more arrows, that's awesome. So for those patients, that was like your 40 and 50-year-olds with early stage degenerative arthritis. They've had splints and braces, but nobody likes those because you need your thumb to actually live life and do things. And so if you lock up your thumb, it's pretty miserable. You can't really do much at all. You can't type on a computer. You can't hold an iPhone. You can't garden or play tennis or whatever it is. So people don't tend to wear them because they really inhibit your activities. So the braces were sort of, yeah, you can wear a brace, but nobody likes that. Then there's occupational therapy. To some degree, some patients find it helpful, but it's not really solving any of the issues internally. Then we move on to steroid injections, and sometimes those can be helpful. PRP injections, sometimes those can be helpful. And then you're kind of stuck after that. There's not really any non-operative treatments that are reasonable to do. And then operatively, then we start talking about joint replacement, which, it's a big step for a 40-year-old to undergo. And so now we're able to do a procedure that can potentially buy people some time and put off, the eventuality of a joint replacement by ideally 10, 20 years when it's more appropriate to do the joint replacement as opposed to when they're 40 or 50. So it's really opened up a whole new ability to treat patients, because otherwise it was, well, you're 45 years old and we've tried everything, so either live with it or have a joint replacement. Whereas now I can say, well, we've tried all the non-op stuff. We can now think about doing an arthroscopy and kind of clean stuff up for you. And ideally we'll buy you another 10, 20 years. And then you have your joint replacement, when you're 60 or 70. So it's been fantastic in being able to, treat patients in a much better way, as opposed to just telling them, well, live with it.
I had a question for you. Talk about common hand and wrist injuries, whether it's the pro and recreational athletes. And what's your thoughts on some of these names, like the skier's thumb or the Jersey finger? You're from the East Coast. I don't think the Jersey finger is what I'm thinking of.
The Jersey Shore.
It's not the Jersey Shore. So can you talk about that a little bit? Because the names are absolutely fantastic. And Jersey finger means a thing on the East Coast.
Yeah, no, it's so the hand world ends up with lots of crazy eponyms, and as Grant knows, people call us the hand weenies because kind of the it's the reputation of the hand surgeons are kind of the nerdy guys who are way into minutia. And Dr. Egelsater used to always say, the leg is just a stupid weight-bearing joint, right? You can cut a leg off and put a piece of wood and give someone a peg leg and they can walk. But the hand, that's a whole nother kettle of fish, right? You take somebody's hand off and they're really debilitated. The hand world, we've got all kinds of names for crazy stuff. Skier's thumb, which actually was a gamekeeper's thumb in the old days, and not because you're playing games, but keeping game, like small game, small animals. So the farmers would be the classic is snapping the necks of rabbits with their hand. And over time, the ligament of the ulnar collateral ligament of the thumb would basically just tear from overuse and all the years of snapping rabbits' necks.
Will, pull that slide up. Pull this, not the rabbits. We don't have a rabbits.
We don't have the dead rabbits. No.
Pull
Okay,
the thumb UCL up while he continues. Keep going, Wade.
So fast forward a couple of centuries, and skier's thumb or mountain biker's thumb. If you can imagine, you're holding a ski pole and you fall, your thumb's kind of exposed out there, and it gets wrenched back, and it gets torn. The ligament gets torn. Or if you're mountain biking, same idea. Your thumb's kind of exposed, and you go over the handlebars and kind of Superman out, and your thumb gets yoinked back. So it ends up tearing the ulnar collateral ligament, which is the kind of, I tell people, that's the ACL of the thumb, right? So if you tear your ulnar collateral ligament, what ends up happening is you can use your thumb and you can move it, and once you're recovered from the acute injury. But the cartilage is going to be stressed in a way that it was not built to be stressed, as the thumb kind of pivots abnormally when you're power pinching and grasping. And so, the reason to repair the thumb UCL, kind of like the ACL, is in a large ways is to prevent arthritis from happening in a pretty short amount of time with the cartilage damage that occurs with, in the knee, we call it pivoting, where you have these moments where the femur and the tibia kind of shift on each other. The same thing in the thumb. So the goal, and when we repair these, is to restore that stability to the joint, so that the cartilage doesn't have that abnormal stress on it, and so folks can have, a good joint moving forward. Looks like here we've got this slide with the internal brace, which that's been, in talking about sort of minimally invasive surgery and innovation in surgery, this has been a real game changer for us in the hand. And really what it does is it allows folks to start their rehab basically, the day after surgery in large part. So in particular with thumb ulnar collateral ligament repairs, in the past, before doing internal braces, we would put people in a cast for 6 weeks. Oops, sorry guys. And after being in the cast for 6 weeks, they'd come out and they'd be really stiff. And then, it takes another 6-8 weeks to get them moving. And then once we got them moving, then we'd add in strengthening. So the whole rehab process was probably more like 4 to 6 months. Whereas now with the internal brace, we can basically get people moving. I get people moving about 5 days after surgery. So my protocol now is a post-op splint. They see the hand therapist at day 5. Splint comes off. They get a removable brace, and they start working on range of motion, so that by basically 6 weeks, they have their full range of motion. And we've already started working on some strengthening. So the total rehab program is basically 3 months before back to normal. So it's shortened their total rehab time by about 50%, which is awesome.
Yeah. And we've seen some crazy ones, right? I know one of your friends is one of the guys that proponents of it kind of taught it to many, and did a lot of the pro athletes. Somebody you trained with.
Yeah. Lots of pro athletes now get the internal brace, and it's kind of the way things evolve, right? Is the pros get the stuff first, and then it kind of trickles down. But at this point, I wouldn't necessarily even think about doing the surgery without an internal brace, because again, it's like an open ACL versus arthroscopic ACL, or an open carpal tunnel versus endoscopic. People just get better faster, and in our patient population here in Seattle, people don't want to spend months at a time either out of work or not kayaking or not skiing or mountain biking or doing the things that they'd love to do.
Well, and for the listeners too. Oh, so I was going to say, the listeners too, it's also important that it's now the gold standard online, right? So people are looking this up. They're already coming to you. We're in a tech heavy market. So it's not like, open ACL in New York is a different animal. In Seattle, you wouldn't even see a patient in the office. They wouldn't show up to your office knowing that you do open ACLs. I mean, and this is, we can say Mike Trout, Bryce Harper. These are some names that we actually worked with Curtis Granderson when he had his UCL tear. You have Drew Brees. I mean, it's pretty extensive. The list is pretty impressive. Yeah, people have had this surgery done. So sorry, Will, keep going.
No, I was going to follow up on that. We're talking about pro athletes, and we know that they kind of endeavor this pain threshold. What are some of the ramifications if you have a pro athlete or a quarterback or a golfer that puts off surgery when they need it, waiting for the off season or something like that? What are some of the repercussions or some of the concerns when you have a high profile athlete that really needs surgery?
Yeah, that's a great question, and sort of that intersection of medicine, sports, business. You start really having different forces at play, right? In an ideal world, somebody has a torn ligament, you get them in, you fix them, they rehab. But with these high performance athletes who getting paid millions of dollars to play, and these are all super competitive people too. They want to play. They don't want to just kind of ride the bench and miss out on a season. So not only are they super competitive and want to be out there, but the teams want them out there, the agents want them out there. So you definitely have to navigate those forces when you're treating a professional athlete or a high level college athlete. As a physician, I always just kind of harp back to, you got to do what's right for the patient. And so, I tell my patients, look, you can play, you can grin and bear it, but there may be serious consequences, down the road, when we, ultimately fix it. If there's, been further damage, I might not be able to make you as good as you once were, because you've damaged that joint to a point where now it's a salvage operation versus an operation where you're going to be basically normal again. So you may play this year, but you may not play for the rest of your career. So and some of this has to do with just timing of things, right? So beginning of the season versus end of the season, teams in the playoffs, not in the playoffs. So, you got to kind of juggle all those factors. But at the end of the day, I think as a doc, my job is to educate my patients. And it is ultimately it's their decision. Patient autonomy is important. And I feel really strongly that, if I give somebody all the information that they need to make a decision that's good for them, then I'm okay with whatever they decide. But I'm not going to sugarcoat it. I'm not going to tell them, oh yeah, you can delay and you'll be fine. I tell them the truth.
Yeah, gotcha. With that, I want to go back, and I appreciate all your insights on these. we talked about scoping, but the wrist scope stuff that you do, especially with the TFCC and some of the ligament stuff, like what sort of newer stuff? You talk about the wrist arthroscopy a little bit. I mean, that's the stuff that the minimally invasive stuff that you're doing now, you're adding more things, right? You're doing different things you weren't able to do before with the scope. Like, what new stuff are you doing with the wrist scope, and why is that beneficial to patients?
So yeah, with the wrist arthroscopy, and especially the TFCC, which stands for triangular fibrocartilage complex. That's why we call it TFCC, because it's a pain in the ass to say. But and that's a pretty common injury from a fall, and people think of it, it's just a wrist sprain, it'll get better. But people oftentimes will end up with sort of chronic ulnar-sided wrist pain, which is kind of the pinky side of the wrist. And oftentimes that's due to this tear of the TFCC, which again, I like to use the knee as an example for folks, because everybody's heard of the meniscus of the knee. The TFCC is kind of similar in that it's the shock absorber for the ulnar side of the wrist, and helps with some stability of the wrist. And so now that, again, we've gotten sort of minimization of the instruments and the anchors, we can start really doing much better repairs of the TFCC, as opposed to just cutting it out. So, like Dr. Garcia does in the knee in terms of repairing the meniscus versus chopping it out. Our ability now to do repairs is much, much better than even 5 years ago, where, we were doing repairs, but they were not so easy to do. And the default was always, just cut the TFCC out, which certainly helps with pain relief, but, it's always better to repair something than chop it out if you can. So that's really been one of the big innovations in terms of wrist arthroscopy, and then also on the ligament side, working to get some better repairs of those ligaments arthroscopically is certainly in the works. To work on instability issues in the wrist arthroscopically, and then starting.
Wayne, would that be like people that have unstable ligaments, like they tear like a mechanism that keeps? Will you describe that briefly for the patient?
Yeah, so like potentially scaphoid lunate ligament repairs done arthroscopically. Again, the SL ligament, very similar to ACL in the knee. This is, we have the ACL of the thumb, that's the ulnar collateral ligament, and then we have the ACL of the wrist, that's the scaphoid lunate ligament. And so, yeah.
Will, they can internally brace those. Do you internally brace those? Don't get Will too excited. You get excited when you say that.
We're getting there. So yeah, that's sort of the next iteration of things is doing those repairs arthroscopically instead of open, and then also maybe doing some cartilage work as well, and just really being able to minimize all our surgeries that we're doing open. So we are definitely pushing the envelope all the time in terms of what we can do.
When you do those scapholunate ligaments, can you do like an arthroscopic assisted? Like that's sometimes what I do for some of my surgeries. Like you can see them go back together, so you don't have to do X-ray. You really can see them touching.
Yeah, process. So that's I think kind of the spot that we're in now is arthroscopic assisted. Really just kind of helps see where you are with the joint surfaces, and when you're closing them down, and then you can even stress the joint and really see that the ligament that you fixed is stable, and you can see it much better than an X-ray, right? You're looking directly at it with the scope versus with an X-ray, you're just kind of interpreting the shape of the bones and how they're relating, but it's better to see it directly.
Yeah. And for the listeners, you're talking about the ankle. A lot of people with ankle fractures, you see those nowadays, all these newer surgeons like Dr. Yee we talk about, or Dr.
Yeah.
Reed, they're scoping the ankle with the fracture of the ankle, right? So they're making sure that the cartilage is not too damaged. Or in the knee, when we have a tibial plateau fracture, sometimes we do an arthroscopic to see how well we line the surfaces up. Because as you said, X-ray is only so good. Plus, it reduces X-ray time, which is always better for the patients and for the surgeon, not having to get fluoroscopy all the time.
Yeah. So one of the things that you mentioned, yeah, I think in fracture work, arthroscopic assisted is awesome. Like I will for wrist fractures, just raised fractures, I'll put the scope in at the end sometimes if I'm concerned about the articular surface, the joint surface, to just make sure that all the little surfaces are well lined up, because with fractures, the biggest thing is getting that joint surface smooth again. You don't want to leave the joint surface with a giant pothole in it, because that's when people end up with post-traumatic arthritic problems, is because the joint surface wasn't fixed properly.
I think that's an excellent point, because it's always hard to see sometimes on these, and you're dealing with even smaller bones. So for the listeners to hear that, like, if you've got some issue, that's something you talk to your surgeon about, right? Like arthroscopic assisted is the new gold standard, not in every case, but in those challenging cases, it's important factor to have in order to preserve the joint, which is really where you're going. It's going joint preservation. I do knee joint, sometimes shoulder joint, and you do hand and wrist joint preservation. And so that's a key point, preservation, because we don't want to be fusing and replacing. It's not nearly as much fun too, right?
That's right.
So, Will, you were about to jump on something. You had a question?
Yeah, no, just a quick question regarding, anyone that's listening that's either a patient or just nothing personal. I really don't want to come see you because I have a broken hand or wrist.
Right.
So is there any hand exercises or stretches or anything that's been documented to kind of maybe reduce the risk? Obviously, if there's trauma, that's something else, like falling off a mountain, grabbing and twisting your arm back. But are there exercises or stretches that you can utilize to, unfortunately, not go see you?
Yeah, great question. So in terms of I think just a holistic view of our bodies in general, there's clear data that just use is good. Sitting around the couch doing nothing, that's bad for you, right? So being active, and that I think is number one, the biggest benefit to longevity in general. So, if you look at sort of those blue zone studies, people who live on hilly areas live longer. Why? Because they have to walk up and down hills all day long, because they're getting exercise. So same thing with hands, and I think that's true of any joint in our body, is using it, staying flexible, working on your flexibility, working on your strength, and ideally, I think there's not, I would say, one specific exercise that's awesome for you. Working on your grip strength, and if you lead an active lifestyle, your hands will be exercised. It's the folks that sit around on the couch watching TV all day. Those are the ones that I worry about a lot more.
Gotcha. Thank you.
We want to, in the sake of time, make sure Wayne can get out of here eventually and meet the traffic. But I want one other topic to talk about really quickly, and then a little bit of fun, and then we can get you out of here.
Okay.
I know Mike Trout had this recently. I've seen you deal with some of the baseball players, on Mercer Island teams, etc. This one happens a lot. We hear this a lot, and this idea of removing the hook of hamate or doing something. Can you describe it to what's the most common first athlete you see with this, and then what's the kind of treatment regimen you normally deal with?
Yeah, no, these are this is a great photo. Actually, I just saw a patient today with this injury. The most common baseball players, and it's an interesting injury in that you would expect it's a blunt force trauma, but it typically happens on a swing and a miss. So where they strike out. And it's the rotation of the bat through the follow through when the hook of the hamate fractures. And so the hook of the hamate, as you can see here, acts a little bit like a pulley on that small finger flexor tendon. And it has a reputation for not healing. The blood supply to there is not great. And so the treatment for this typically is just you excise that portion that's where that arrow is pointing. So the top part or the hook, as opposed to the body of the hamate. And then you kind of smooth out the fracture zone because you don't want the flexor tendon abraded by the bone that's been fractured. It kind of acts almost like a saw on the flexor tendon. So you smooth out that fracture, and it's an operation that works really well in terms of relieving pain. And getting people back to playing baseball. Golfers can get it as well. And then the other sort of cohort of folks who break their hook of the hamate are people who kind of use their hand like a hammer and are banging on their hand. There's a board in your porch that's a little bit up, and so you smack the board down with your hand, and you can injure your hamate that way. It's interesting. It's an interesting injury because you'd think it was more of a blunt force injury, or when in baseball when the batter connects with the ball, but it's actually when they strike out when it happens.
Is it the hand? Is it the bottom handle of the bat that's rounded, that's coming through on the follow through and grabbing that part of the hand? Is that
some of that? Also, it's just the force transmissions. As the hands are turning over, and you've got this giant lever arm, which is the bat. Yeah. And it just torques the hand just in a perfect way to break off the hamate. Really common in actually pro baseball players. We see it kind of pretty regularly.
And you don't see it with golfers?
Yeah, you see it with golfers too. Okay. Usually with golfers, it's more they hit a really fat shot and their club gets stuck in the ground, and then their hands kind of rotate over it. But it's a gratifying injury to treat because you just take out the hook of the hamate, and people get back really quickly. So
that's interesting.
Awesome.
Yeah.
So I guess since you're well known for all your hand surgeries, but actually what the viewers may or may not know, if they're doctors or patients listening to this, you actually are more popularly known for something else. So as of now, you are now famous for other things. So I'd like to show the viewers and maybe better understand and hear the background story behind this.
Right. Oh yeah. Yeah, this is my new side gig here.
And he's smiling the whole time.
It loves it. Amazing.
Well, pull up his followers.
So this director in the background reminding me to smile at all times.
That's pretty impressive. I think it's go to the main, go back. I think it went up since we started the show. When I told you how many followers he had, it literally went up between this entire show recording because Will just changed it.
Yeah, it's gotten kind of crazy. We this is something that's just kind of come out of the blue for us. It was kind of a joke. and started actually December 1st last year after Thanksgiving. My wife is used to be a private chef, so she's an awesome cook, and all our friends and family know that she's amazing. She should open up a restaurant. But her classic Thanksgiving is to die for, and it's our family favorite. My wife was actually born on Thanksgiving, so it's kind of a big deal for our family. And she does this really traditional Thanksgiving with, giant turkey. Usually it's like a 28-30 pound turkey, and 4 different pies and all the sides you could ever want. It's a massive undertaking. And so this year she's like, we're not doing Thanksgiving. I'm tired of it. And
What?
everyone, we were so depressed because it's literally our whole family looks forward to it every year. She's like, I want to make a turducken. For those of you who are John Madden fans back in the old day, if you look up some of the videos of John Madden in New Orleans, this comes back to the turducken. And so a turducken is basically, it's a turkey and a chicken and a duck all stuffed inside the turkey. And so my wife asked me to learn how to debone the turkey and chicken and duck, and then so I watched a couple videos on how to do it, and so we made this turducken. And at the end, you basically sew the turkey back together, so it looks kind of like a turkey again, and it's stuffed with the stuffing and the chicken and the duck. And I don't know why, because we never video stuff, or we hadn't videoed anything previously. We took this video, and it was like 3 a.m. I just got back from skiing, and so it was kind of an unhinged video in general. So we actually had Thanksgiving at a friend's house, and there's about 4 other families there, and we brought the turducken, and one of the docs, actually one of the families who was there, she's a doc, but she all night long was like, you got to post that video, it's awesome, and blah blah blah. Great. And so we made a TikTok account. We just posted the video after being browbeaten all night, and the next morning we had like 50,000 views on this video. And my wife, who works in social media for a skincare company, she's like, that's actually really odd because you have no followers, and that's a lot of views for a brand new account with no followers. And so then we posted another video, and that got like another 100,000 views pretty quickly. And so then we just started posting these videos of me cooking. We call the account Seattle Hand Doc. And fast forward 11 months or 10 months, we have 360,000 followers on Instagram, about 350,000 on TikTok, and it's become our nighttime activity, our second job for both of us. So yeah, we're now gotten to the point where starting to get recognized by people out and about, and different companies are reaching out to us to collaborate with them, and so it's been really fun. I've actually learned a lot. You'd think as a surgeon I'd have good knife skills, but when it comes to the kitchen and chopping onions, mine are terrible compared to my wife's, but I'm getting better.
In general, you have to realize your wife's better than you at pretty much everything.
Oh yeah, that goes without saying. Right?
You and I already figured that out.
Yeah,
knows that.
Yeah, no doubt about it. yeah, it's been really fun because traditionally my wife did all the cooking, I did all the cleaning, but now we kind of do everything together. So it's brought us together to some degree. Although I screw up almost every night and I get yelled at, but that's okay. For the most part, we're having a good time, and yeah, I've learned a lot, and it's fun. It's brought us together, which is really the best part of all of it.
What's your highest views on a video so far?
Oh wow, we've got I think it's still our nachos video, which is up. It might be 12, 14 million views. Yeah,
That's
it's
insane.
pretty crazy. And we've
Dude,
got,
when are you gonna have speed? When are you gonna have speed on your cooking show? You need, that's the key. He's all over the place.
Yeah, no, it's be awesome.
What do your kids think about this? I mean, they've got to be like, mom and dad is rocking it. I mean, the younger generation.
Oh, they're on it now.
This is supposed to be their
so that's been
I've seen them on there, but what are their thoughts?
It's been interesting to see that. So we have 5 kids, so I think that's part of the draw in terms of our account. So our 2 college kids, from the get-go, they were all in, and they thought it's awesome. At the time they were in middle school. Now they're freshmen in high school. We have twins. They were horrified. They can't, because when you're 13, 14, 15 years old, nothing your parents do is cool, right? You just your parents are the worst people ever. And then my junior, now senior in high school, he was kind of lukewarm on it. And so, but now the kids have gotten around to having a good time with it. And we pull them in on some of the videos. The 3 older kids are definitely more into it than the youngest, the twins, but we can cajole them into a video or 2 here and there. And actually, my daughter Charlotte, one of her videos, I think, has about 4 million views. So she's a rock star.
Wow.
But yeah, it's been fun. It's and I've learned a lot in terms of just the whole social media world and influencers. And to me, that's one of the things that I found most interesting is just that, it's a lot of work. And I used to kind of poo-poo the idea of social media and influencers. And, you look at people like the Kardashians or Jake Paul and Mr. Beast and, what they're doing. And, someone was basically uneducated like me would just say, well, that's ridiculous. Why do they have so many, why are they making millions of dollars doing this stuff? And now that I've, just scratched the surface of this whole social media world, I get it. They have a product that, people enjoy, and they work at it. I mean, they're putting up content every day. It is a job, no doubt about it. And so for me, that's been kind of fascinating to come through that experience to really have an appreciation for what people are doing out there.
So as we saw, we went too long. We have exactly 1 minute and 22 seconds before we have to stop because of the 1 hour social media limit. So you did a good job, Wayne. You maxed it out.
Awesome.
Thank you so much, Dr. Wayne Weil, a Seattle hand doctor, orthopedics surgeon, hand, wrist, and elbow specialist, TikTok influencer, you name it. They've got too many titles. If not, we'll spend the next 5 minutes talking about the titles. Most importantly, thank you for spending some time with us and educating the listeners and patients and everyone. So once again, thank you for your time and have a good night.
Awesome.
Thank you,
Thanks,
Wayne.
guys.
Have a safe drive home.
All right. Appreciate it. Been fun. Thank you very much. See y'all.